The first thing to say is that ARREST-CF is the Australian Respiratory Early Surveillance Team for cystic fibrosis, and we started off as a group following on some data that were generated in Melbourne in the mid-90s that showed that inflammation and infection occurred very early in cystic fibrosis using bronchoalveolar lavage to get samples from the lower airways. In 1998, Pete Sly, when he was working here, encouraged us to start doing exactly the same protocol. And then we were fortunate in 2005 to receive money from the US to expand the program to include computed tomography, CT scans. And at that time, Harm Tiddens, who's one of our collaborators, was fighting an uphill battle trying to persuade people that CT scans were a much better way of demonstrating the severity of CF lung disease than conventional physiology. And this rang true to us because the year before, in 2004, some data from the United States also showed that young kids seemed to have CT abnormalities. And clearly there was a limited range of tests available for us to investigate young children with CF lung disease. And so we included CT initially as a bit of a screening tool to see whether a very limited investigation at very low radiation doses could pick up any abnormalities, because we figured that if we weren't picking up very much with this screening test, it wasn't probably something worth persisting with. But we did find a lot of changes in a lot of kids, and we recognised that by the time children were 5 or 6 years of age, at least half would have some signs of lung disease, and that at 3 months a lot of them had evidence, 80% of them would have evidence of disease in the lungs, whether it be through inflammation, infection or changes on CT scans. So this really focused our attention on early lung disease. And we've been advocates now in the broader community for early intervention studies to try and prevent lung disease, because most of the work up until now in terms of CF treatments have been in established lung disease. So
I can run the audio for the videos off there, run the slideshow through there.
All right, okay. So I'll skip through some of these. This is just to make the point that this is a big group, and it's present in Perth and Melbourne. And Sarath Ranganathan, I'm very proud to be associated with Sarath, and we've developed a very strong collaboration between the two centres. Colin Robertson, who's not here at the moment, I think he's stranded at Perth Airport, but will be coming. And Pete Sly, who we still see as one of our own, in Perth, even though he's situated at the Perth Satellite Centre in Queensland. So we've far west Queensland. Far west. We're very fortunate to have developed over the last 7 years some very strong collaborations internationally in Europe, in North America, and in Canada. And I'll say a little bit about those in a minute. Currently, our total funding is about $1 to $2 million a year, give or take. It depends on what you see as a source of funding, including some of the benevolent funding, but also we've put a lot of effort into getting competitive funding from the National Health and Medical Research Council, the National Institutes of Health, which we've been successful this year with 2 grants, and we've also picked up little bits of funding along the way from CF Australia and other sources locally that contribute to that. The relevance of that figure will become apparent in a moment. Our focus was really on early lung disease, and this data really shows why. These are survival data from Verona, which is the centre that's had newborn screening for over 47 years now, looking at the trajectory of their patients. And in the red and black, you can see the patients that received either a lung transplant or who died, and in the light blue, the ones who were survived beyond the age of 40. And what's apparent is that these lines are separating by the age of 10. So things are happening in very early life to determine a trajectory. Now, our role in our research has been to try and identify some of the factors that predict that trajectory and see if we can intervene early to prevent the sort of lung disease that results in these sort of trajectories. This was the early surveillance program that was started in 2005, that any child born in Perth or Melbourne from 2005 would have been involved in. An initial evaluation at 3 months with lung function, bronchoalveolar lavage, where we get samples from the lung looking for infection and inflammation. Epithelial samples, this is the lining cells of the lung, where we look at the way that the abnormal mutation affects the function of those cells, and chest CT scans to give us indications of the lung structure. This is a demonstration of the biobank just to see how big it is in terms of the samples we've collected and the lung function data and CT scans. And really the indication here is 1,500 BAL samples, probably coming up to 1,400 or 1,500 CTs now in the bank, and well over 1,000 lung function tests. It's the largest archive of early lung disease anywhere in the world. Our early observations, as I've said, disease begins early, and Pete Sly published that in 2009. We followed up with a cross-sectional study showing that it increases with age. Lauren Mott, as a PhD student, published data showing that the lung disease is progressive early in disease and early in life. And the important thing to say is that this is very mild disease. This isn't awful lung disease. It's mild, but we can detect a change, and that's really important because it means we can intervene early and demonstrate that we've prevented progression at a very early stage. We've also shown that this is reflected in physiology as well as lung structure. And the physiology group, headed by Graham Hall and Sarath, have really been working very hard in this area. And this is just an indication of some of the bugs that we find from bronchoalveolar lavage. These bugs on the far left-hand side are all the bugs that we find in older kids. But we can find them as young as 8 weeks or 24 days in one case, just showing the value of getting a sample. Now, there's been some discussion about the value of bronchoalveolar lavage, but this, I think, demonstrates that a lot of the bugs that we can find, you wouldn't find by any other means than doing a bronchoalveolar lavage, and we can find them very early on in life. So we've been working very hard in terms of disease pathogenesis, but we've got a certain amount of tools, and for the man with a hammer, everything's a nail. So we want to see what other tools we can bring to the collaboration and the research. And this was the schematic that we developed for the collaborative research funding. And I think the important thing to see here is that there are 4 components that we think make up our vision. One is understanding disease mechanisms at the top, trying to find predictors and endpoints early in life, predictors that can tell us what kids are going to have a more severe course, and also endpoints for clinical trials. A lot of the work in clinical trials has been done in adult patients, where the endpoints are lung function. And unfortunately, that excludes the very group that we're interested in, which is infants, because we feel we can have the biggest impact early in life, yet there aren't the endpoints there for clinical trials that drug companies and the regulatory authorities will accept for drug regulation. So we've been working very hard on endpoints, and the CT endpoint is one that has now been accepted by the European Medical Agency for use in clinical trials in young kids. So we've already had an impact there, and we now will be able to negotiate clinical trials with drug companies using this process and using CT. We've started the first clinical trial in infants to prevent lung disease, the Combat CF study, and that's got up this year, and we'll be recruiting in earnest next year. But the one area that we feel we're less well equipped to deal with, and where we've really decided to put some emphasis, is on therapeutics. There's no reason why researchers in Australia shouldn't be discovering new therapies for cystic fibrosis. We've got the talent here, we've got the resources, we've got the families who are willing to take part in the research, and all we need is the funding and resources to go the next step. The significance of the funding at $1 million per year becomes relevant when you look at the sort of program we're talking about is a $10 million a year program. So we really do have to think seriously about fundraising in order to support this sort of research. One thing I should say is that the sort of funding that was undertaken in the US that led to the discovery of ivacaftor, Kalydeco, was raised by CF associations, by parents, by friends, and they drove the change to discover new drugs. And the time from discovery to approval was around 10 years, which is remarkably short in terms of getting a drug approved. So it is perfectly feasible to discover drugs in Australia and push them through to therapy with the right resources. This is really an indication of the people, the CIs that were involved in the Collaborative CF Research Centre application. We don't know whether any money will be trickling through to us from this, but what it has done is set up collaborations worldwide that we will continue to look at funding through competitive means. This is Harm Tiddens now. I'm supposed to be running this from here, the sound from here. So I'll see how this works. It might not. There we go.
Hello, I'm Harm Tiddens. I'm working as professor at the Department of Pediatric Pulmonology and the Department of Radiology at the Erasmus Medical Center in Rotterdam, the Netherlands. The Erasmus Medical Center is one of the largest medical centers in Europe and currently employs over 15,000 people. Imaging is one of the three main research areas of the Erasmus MC. I'm heading the Erasmus MC Lung Imaging Group, which is a unique collaboration between researchers of the Radiology Department, the Bioimaging Group Rotterdam, and of the Pediatric Pulmonology Department. We have an intensive collaboration since 2002 with the group of Professor Stick from Perth and from Professor Phil Robinson from Melbourne. The ARS-CF surveillance programs in young children includes chest CT and is therefore complementary to our monitoring program that we run in older children. The ARS-CF program is unique in the world and improves our understanding substantially of early CF lung disease. In addition, it allows us now to initiate early intervention study, which is of key importance, of course. The Erasmus Lung Imaging Group is eager to continue our collaboration within the ARS-CF network. Thank you.
Okay, so